Thank you very much, Philip, for your very nice talk, instructive. Now the floor is open for discussion, so please go to the microphone and state your name and where you come from and ask your burning questions. If no one is walking to the mic, Norbert is... Yes, please come to the mic. In the middle row here, there's microphones.
My question is about the comparison with HMOs, synthetic HMOs and natural HMOs. You say that the HMOs in the mothers are different, specific to all the mothers. Is there, so my question, are they, the synthetic HMOs, are they different, really, no, really the same with the synthetics in the formula? Thank you.
Does it work? Yeah, okay. Yeah, so thank you for that question. I don't know if everybody understood. The question was whether the synthetic HMO in the formula are exactly identical to the ones naturally found in breast milk. The answer is yes. In fact, they are they're really identical. And this is actually also what was approved by the regulators, that we have identical molecules and basically almost no contaminant of any unknown thing from the synthesis pathway. So they're extremely pure and identical. So compared by different analytical methods, including NMR, structural analysis, that they're exactly identical. But for the moment, we have only very few synthetic ones. That's the difference to breast milk, where you have more different ones also, and more complex ones.
Yes, please.
My name is Abdurrahman al-Nimri from Kingdom of Saudi Arabia. I don't know what is the trial, why only in the full-term baby? What is the effect of this HMO in a premature formula? Because most of this biological function, we can get it and we need it in a premature formula as a neonatologist.
So from my perspective, I can only recommend that we find breast milk. I know that in Saudi Arabia, this is more difficult to have breast milk banks. We know that this is the most sensitive group, but we don't know yet really, what is the contribution of HMOs in the beneficial effects for to preterms that we get from breast milk. So we think that could contribute, but I think we're still too far away to have today an application with HMO for preterm. We would need to really have the randomized controlled trials or intervention trials to test.
The other aspect is we have a lot of probiotics evidence growing up. Now we have a lot of evidence in these prebiotics. So which one to choose as a pediatrician? Shall we go with probiotics or shall we go with these prebiotics or HMO? Thank you.
Well, if I may, I can say that we need more clinical data, of course, for preterm babies. But there are some in vitro studies which are very promising for HMOs in animal studies to protect from necrotizing enterocolitis and so on. So I think that the debate is open whether we will go for or for probiotics or for HMOs. But on the other side, it's obvious that if it's shown that HMOs are clinically in preterm babies equally effective as probiotics, that they are safer and easier to administer than probiotics. So then probably they will win the debate. But today it's too early to answer your question. I don't know if one of the speakers has something to add to it. But
no, I think you're right. I think it's too early in a way to have a recommendation besides breast milk for preterm. in terms of HMO. I mean, for probiotics, I think there is quite good evidence.
Yes, so please, next question.
My name is Gu Fangjie. I'm from Wageningen University. I have a question because you mentioned the mothers, they produce, have very different levels of 2FL in their milk. So for the mothers who do not produce enough or do not produce 2FL in their milk, so besides breastfeeding their babies, do you think it's necessary to feed their babies with 2FLs as a fortification?
So this is a difficult question because I don't know the answer. I would say maybe yes, maybe not, because sometimes you might have redundancy that we can associate with one molecule, a problem, but maybe that is a false piece, and we don't know yet whether that is really true and a causal relationship. So I think it's intriguing. It's intriguing us also at Nestlé Research to try to understand whether supplementing in some cases would make sense. I think we need to try to find out with new studies. Yeah. I'm sorry to not have a more clear answer.
Thank you.
So thank you. So we have 2 more minutes, so please, and 2 more questions. So short question and short answer, please.
Good afternoon. Thank you for this presentation. I'm Hélène Tamen from Toulouse in France. And I have a question. I would like to know if there is any correlation between the development of colic in infants and the HMO composition in breast milk.
You want me to answer?
I can only say from this study we didn't see any difference in the two groups.
Yeah, so in this study, actually, that Philippe mentioned, we saw only a difference at few time points in the C-section born infants, where the HMO had an effect with slightly less colic. But I think, again, we're too early there, so we have involvement in a big cohort in the Netherlands to try to address that question also, whether we see any association to HMO composition and colics in infants. We have some animal data that indicate, yes, that could be the case. Now, whether that is a direct effect of HMO or any molecule that increases microbiome activity, we don't know yet. In terms of breastfeeding benefits, it's not so clear whether breastfeeding actually is a beneficial effect for colics, in my view. And I think there is, again, a situation with many, many factors that play into this situation when you have colics, including parents' psychology, maybe.
Thank you. Final question?
Hi, this is Robert Duitsman from SICKES in Toronto. I was pleasantly surprised by your inclusion of a cohort from Bangladesh, a low-resource setting cohort, because I'm a little bit worried if you focus your studies only on healthy infants and have growth or infections as an outcome, you'll have a lot of negative studies. Mm-hmm. Can you speculate, can you first tell me a little bit about knowledge of ongoing work that's going to be done in either low-resource vulnerable populations, or secondly, children beyond infancy in a vulnerable state, for example, CF or other chronic disease patients?
So I'm sorry, I can only comment on what we do from Nestlé Research, at least in terms of HMO research in the developing world, like in Dhaka, Bangladesh, where we do actually also an intervention trial to try to understand whether during acute diarrhea, where we see a dysbiosis between Bifidobacteria streptococci or Bifidobacteria E. coli, that we try to rebalance that faster back so that we don't get infants into prolonged diarrhea, which is a big problem that is partly solved but not completely solved, and maybe we can also help there to resolve the diarrhea quicker. So that's what we do additionally there, besides the cohort study that I mentioned. And in the cohort study, we have now quite a lot of parameters that we try to understand and try to find actually specific risk factors that are in the microbiome, what we see, for different infections. And we go to etiology also to better understand. We have also growth parameters, but again, all those are not yet completely analyzed, but we try to get a handle on this, and antibiotic use, malnourishment, and so on. And maybe I forgot another cohort that we have actually in India also on breast milk composition and parameters in infants, on growth, where we have specific the problem of small for gestational age, where we try not only to understand HMO composition and the impact that could have on growth, but also other milk components in the breast milk. So they have actually a very large study ongoing on analyzing breast milk from different geographies, including, let's say, developing countries or more disadvantaged populations. We can discuss more later if you wish.
So I would like to thank you all for the interest you've shown and ask a big applause for our two presenters.
Thank you.